Boa tarde, muito obrigado por la invitação, professor, e por sua apresentação. I will speak in English because my Portuguese is not good. So thank you very much to the organizers for inviting me to give this lecture. Can you hear me well? Can you hear me?
Yes, we can hear you.
Okay. So let's see if this moves around. Okay. These are my disclosures. So what is the current situation with antiretroviral therapy? As you know, many people still suffer stigma and discrimination associated with drug intake. For some people, there is a psychological impact linking everyday intake and having an incurable infection. Every day I take my pill for cholesterol. I'm not suffering, but if I would have to take a pill reminding me that I'm HIV positive, probably the situation would be different. So far, as you know, we don't have any kind of cure, so it's a matter of a lifelong treatment. Some patients have issues with pill size or swallowing pills. There are risk of non-adherence breakthrough, and life needs to be organized. You need to take your pills with you when you travel in the weekends to maintain the medications. You need to refill your bottles, and for that you need prescription, and in some cases there might be discontinuation for different reasons, like surgery, disruption of drug delivery, etc. So what do we mean by long-acting, and why long-acting drugs? I will try to discuss with you these issues here. Are drug concentration the same for everyone? What is the PK tail? Do we need to worry about it? What about drug-drug interactions? And what is the willingness of people living with HIV? And finally, can we apply long-acting to PrEP? By definition, a long-acting drug is a drug that is slowly absorbed and slowly excreted. And so it persists in the circulation and tissues and is effective over a long period of time, regardless of the way in which you introduce the drug in the body. In this graphic, you can see the situation, what happens with a long-acting drug in the blue line. You can see that you reach a given concentration and it lasts for a long time, different from somebody that takes a drug every day and can have sometimes a situation in which via suboptimal adherence, the concentration goes below the minimum effective concentration, and this paves the way for selecting resistance. So, and eventually you can also have an overdose level that puts you close to toxicity. This is different with long-acting drugs, which is much more regulated the distribution of the drug. So the benefits, the potential benefits that we can see is sustainable results in prolonged half-life that disrupts you to infrequent dosing, a potential lower total dose. It protects the health privacy, is a barrier against poor adherence, and when not administered orally, for instance with injections, the gastrointestinal barrier is bypassed. And other infectious diseases might be also suitable for long-acting or extended-release drug formulations like tuberculosis, hepatitis C virus. Imagine just for a moment that we have a drug for hepatitis C virus that could be given only with one injection and the patient could be cured. Hepatitis B virus, malaria, Ebola, etc. When the patients are asked about the nanotechnology that could drive them to get the medication once a week or once a month, you can see that effectively the majority would prefer to have the medication once a month. No, as the more prolonged the period of time between doses would be better for them. As you know, when we swallow a pill, it has to pass for different steps. Absorption might be pH dependent, as it occurs, for instance, with atazanavir and proton pump inhibitors. There might be drug elation. There is a first pass metabolism, and there are also involved GI tract transmembrane transporters. This disappears when you use injectables. And long-acting drugs have shown to be effective and often are preferred in other specialties like antipsychotics, contraception, and bisphosphonates for osteoporosis. So we are not inventing the wheel here. It's just applying a technology that is already in use in other specialties. There are different ways to provide extended release or long-acting antiretroviral therapy. For now, we only have long-acting injections, which I will refer to in a minute, but there are also studies in oral nanomedicine, infusion pumps, vaginal rings, like the pivirine for PrEP, subdermal implants, very interesting perspective, and microneedle drug patches. So as you can see, there are different ways to approach to long-acting heart. And in the case of the implant, this is the real size of an implant that, as you know, many ladies are using to prevent unplanned pregnancy. And this is just an example of a model of an implant, a subcutaneous implant, in which in this case is used with TAF and is delivered very slowly and can be changed every 6 months. So this is really frontline technology that is coming forward. Well, what are the advantages of implant? Well, you can remove it if they are an adverse effect. Could provide therapy for months or eventually years. They offer more stable pharmacokinetics, and you can really touch and see if the implant is present or not. Some of the disadvantages is that you require a minor surgical procedure to insert and to remove eventually if it's not bioerodible. But patient doesn't determine the duration of use. There are very complex regulatory issues regarding this because it's a completely new device. And it's difficult to imagine that this would be moving to the generic marketplace, which is almost needed in many parts of the world. This is a schematic representation of the difference in the lymphatic uptake, distribution and retention of lipid nanoparticles in the lymph node in comparison to free drug. So free drug, as you can see here, enters, is distributed and fastly is excreted from the lymph node, while the nanodrugs tend to persist inside the lymph node in a much longer period and is slowly excreted. So let's think about what we have in the market, cabotegravir and rilpivirine. There were 3 phase 3 studies. The first one was done in naive patients. The study was what's called the FLAIR study that showed the rate of viral suppression of 93.6% and showing non-inferiority to an oral regimen. This study was published by Chloe Erkin in the New England Journal of Medicine. Then we have the ATLAS study, which patients with viral suppression at least 6 months on 2 nucleosides plus a PI and a nucleoside or an integrase inhibitor were randomized to continue ART or to change to cabotegravir rilpivirine oral for 4 weeks and then intramuscular monthly with 92% of virological suppression and again showing non-inferiority presented by Swindles. And the last one is the ATLAS 2M, in which the comparison was made between every 4 weeks and every 8 weeks, providing cabotegravir rilpivirine, and non-inferiority was shown for the 8 weeks schedule. And this was presented at CROI 2021. If you look at the pooled analysis for ATLAS and FLAIR, be reminded that FLAIR is the study in naive patients and ATLAS in previously exposed patients with virological suppression. You can see that the virological non-response that applies for ATLAS was below 2%, and the virological success, which applies to the naive study, is 93 and 94% respectively. So non-inferiority was shown in both cases. As you can see here, the 95% confidence interval crosses 0. The acceptability was really better for patients on injectable way. 90% found injection site reactions totally or very acceptable, and only 4 patients withdrew due to the injection site reactions. So this is really important because 97% of the responding participants preferred cabotegravir rilpivirine. You could argue that patients that participated in this study were ready to receive injections, so they probably do not necessarily represent 100% of the population. But eventually, we can say that at least in this type of participants, the injectable way of receiving antiretroviral therapy was very well preferred. So it was approved by the FDA in January 2021 as a monthly injection, and in February 2022 as every 2 months injection. That means every 8 weeks. There are some challenges related to this. The frequency of in-clinic injections so far is not auto-injectable by the patient. Some concern was raised about people with obesity with high BMI. The need or not of an oral lead-in phase, which is now solved. I will talk about that in a minute. And some logistic and operationalization rollout and uptake hurdles. The Atlas 2M, the study that I talked about, was a study in which the adult population receiving cabotegravir long-acting plus rilpivirine long-acting every 4 weeks or receiving standard of care arm were later on randomized to receive every 8 weeks 600 milligrams of cabotegravir long-acting and 900 milligrams of rilpivirine long-acting, or every 4 weeks receiving 400. See the difference in the doses. This is once a month, this is once every other month, and 600 instead of 900 milligrams for rilpivirine. Primary endpoint was proportion of patients with more than 50 copies as a virological failure by the FDA's snapshot in intention to treat. And as you can see here, the results of virological success were really very important in the analysis intention to treat, 87% and 86% respectively in the Q8 week and Q4 week, and in the per protocol analysis 88 and 86. So regarding the tolerability, almost 100% of injection site reactions were graded 1 or 2 with a median duration of 3 days, and 2% and 3% respectively were due to this injection site reaction, which is really a minority. So confirmed virological failure, 2% in the every 8 weeks treatment, and less than 1% in the every 4-week treatment. What are the risk factors associated with the risk of virological failure with long-acting cabotegravir and rilpivirine? As you can see here, rilpivirine resistant associated mutation at baseline has a odds ratio of 40.36. Trough concentration of at week 8 for rilpivirine has also odds ratio of 5. Being infected by the HIV subtype A6 or A1, which is prevalent in Eastern Europe, in Russia, and in some parts of France, also increases this. And the BMI at baseline was really minor. The interesting thing is that if you have none of these 4 factors, your chances of being successful is 95%. If you have 1, it doesn't change. If you have 2 or more than 2, then it goes down to 71%. So the indication, as stated by the FDA approval, is that you can use this combination in patients that are replacing the current antiretroviral regimen, provided that the patient is virologically suppressed on a stable antiretroviral treatment, with no history of treatment failure and with no suspected resistance to either cabotegravir or rilpivirine. Regarding the BMI, the body mass index, you can see here that in individuals with body mass index less than 30, that means they are not obese, 94 and 92% respectively for Q8 week and Q4 weeks. But eventually in individuals that are obese with more than 30 kilograms per square meters of BMI, the results are very similar, 91% and 92%. So the trough level remained above the target value regardless of dosage schedule or BMI. Probably in individuals that have a higher BMI, you need maybe needles that are larger, that are longer than the ones you use people that are not so far. The recommendation is based on the FDA wording, in which the DHH's guidelines recommend as an optimization strategy for people with HIV, having no baseline resistant to either medication, no prior biological failure, no HPV infection. Be reminded that this combination doesn't act over hepatitis B virus, are not pregnant because the pregnancy has not been studied, and are not receiving medication with significant interactions with cabotegravir and or rilpivirine. Initially, before the injection phase, patient had to receive oral cabotegravir and oral rilpivirine for 28 days to assess tolerance. Now this became optional after we saw the results of the study that I will show you in a minute. Again, the loading dose is 600 milligrams and 900 milligrams if you are using it for as the first cycle of injection. Afterwards, if you go for the monthly injection, you use 400 milligrams and 600 milligrams respectively. If you use it every other month, you continue with a higher dose. Be reminded that repeating long-acting requires cold chain, which is a difficulty probably in sites like Africa. And the injection has to be in the gluteus medius. You need to be careful. It cannot be injected in other part of the body, which might be a problem in patients with obesity, as we spoke about in a minute ago. And you require a private place for injections. And there might be also a problem for some patients, particularly transgender, that might have Botox implants, and this might be a relative contraindication for the injection. So you can read in the DHHS guidance. I will not walk you through over the slide, but you have the precise indication how to administer this medication, and can be done only by a healthcare provider. So it's not the case as we had with T20, in which the patient could inject himself or herself, or a relative could have done this. So far, it's only for healthcare providers. So regarding the issue of needing or not the oral Nidin, in the FLAIR study, be reminded that the FLAIR study was in 8 patients. The participants that were receiving dolutegravir and macrolide initially, that achieved biological suppression after 28 days, could switch to monthly long-acting cabotegravir and rilpivirine at week 100. This was the comparative. So they were offered to switch to long-acting cabotegravir and rilpivirine, and they could select by themselves both direct to inject or have another lead. And as you can see, the efficacy was 99% in the direct to inject and 93% in the oral lead, with very low rates of virological failure. So in March 2022, very recently, the oral lead became optional according to the FDA approved prescriber information. So it's not mandatory that you use the lead for using cabotegravir. What are the populations that could benefit from long-acting ART? Well, basically you have the typical patient that is virologically suppressed, deciding an ART switch patient that is adherent to the medication, and he or she will come back to the clinic to get the injections. And also now there is a study running by the ACTG trying to cope with patients with suboptimal adherence to oral therapy. And this is done with incentive and mobile vans. And you can imagine that the person that is in a difficult social situation might not be taking the pill every day, but might be seen every other month and receive an injection and have viral load. So some considerations you have to take in account. First, you have to discuss with your patients if it's really his or her choice. Patient have to be virologically suppressed without any prior virological failure, without resistance to rilpivirine or cabotegravir, and also if you have the subtype, if the patient has a subtype A1 or A6, you need to be careful with the use of this combination, which which fortunately in our region, neither in Brazil nor in Argentina, as far as I know, A1 or A6 subtype is circulating. As I said, no active hepatitis B infection, no drugs with significant interaction like rifampin, logistical issues that the cold chain storage for repividine, the oral lead-in that is no longer needed, and the gluteal large volume injections every other month. Monthly or every other month follow-up visit for the proper control for our patients. And how to deal with this injection and visit, which are to be taken into account. So this is what happens when a patient misses the next dose. The concentrations start to fall, and in the yellow box, it's a situation in which the patient might come, the blood concentration might be inferior to the minimum inhibitory concentration needed for combating HIV. So this is a risk that we need to take into account. Patients need to be compliant with the time of injection. And the reason for that is that the cabotegravir and also repividine have a kind of tail. And this tail, that means the concentration that remains for weeks or months after the injection, is different for repividine and for cabotegravir. Here you see that it's also slightly different between male and female. In females, it tends to be a little bit long. But anyway, when a patient receives an injection of cabotegravir, he might have cabotegravir for about 1 year or even more. So it's very important that the patient comes back to the clinic and we have a good contact with him. We talked about interactions, and in our country, tuberculosis is still a problem. And as you know, rifampicin is a first drug for treating TB. So in this modeling, you can see how the concentration goes down when you use cabotegravir alone or use cabotegravir with rifampicin. And the same happens with the repividine. In either way, if you use it every 4 weeks or every 8 weeks, there is a slight evident reduction in the concentration of antiretroviral drugs. So we need to find solution for different issues regarding injections. First of all, to reduce the injection volume, which I know the laboratory that uses cabotegravir is working on that. Eliminating the requirement for another lead-in, this is the done deal. Strategies for preventing and managing adverse events, coverage of the long decay data that I talked about, and those strategies for populations that are not currently selected, like children, adolescents, and pregnant. So, as a take-home point for long-acting injectable AMT, before we discuss briefly the issue of PrEP, long-acting cabotegravir and repividine is now approved for monthly and every 2 months dosing. Virological failure occurred in a small number of patients on long-acting cabotegravir and repividine in spite of time dosing and medical information occurred 8 weeks dosing compared to every 4 weeks. But be reminded that there are factors for that. Being A1 or A6 subtype, having A1 or A6 subtype, having the patient resistant to repividine or very much dependent from repividine and repividine. And there are additional long-acting agents that have been found to be effective. And I will show you that this is a partial list of different compounds with different classes, fusion inhibitors, BNABs, nucleosides, non-nucleosides, inhibitors, protease inhibitors, etc., that are being studied now as long-acting agents. Some of them will not make it to the market, some of them probably will. We have 2 interesting compounds to briefly mention as new long-acting agents. One is the acapavir, a capsid inhibitor from Gilead Sciences. It's a new mode of action. It's a capsid inhibitor. Single dose achieves a reduction of 2 logs at the day in therapy. And after 3 oral doses, you can give subcutaneously every 6 months. It has a good safety profile, relatively low genetic burden. Islatravir was a very promising drug. I have to say it was, because now it has been suspended in terms of development because unexpectedly, regardless of the excellent antiviral activity, medication show decreased CD4 counts and total lymphocyte counts. So it's now being reviewed, and hopefully we'll come up with a new class that much more effective than a capability. By the way, the capability is clear that it's not very similar and those laboratories signed an agreement to develop to carry the dual therapy regimen with a capability standard that is now on hold. Just for you to see, with very low doses for slattery, 48 milligrams in an implant. You see here, after 12 weeks, that's the concentration that you get. And with 52 milligrams, you see even higher, and 56 milligrams, even higher, until they, so probably is used whenever it's again on the street. Could be used maybe as a drug for PrEP, for using it subcutaneously with once a year or once every 6 months. Lenacapavir is, as I told you, is a capsid inhibitor that works in two different ways. It's in the capsid disassembly and nuclear transport and the capsid assembly. And it has been tested in 2 types of patients. It has been tested in heavily anti-experienced people living with HIV. And as you can see here, the results were appropriate. 83% in sports phase 2 study achieved net 50 copies. People that were really in the situation in which they didn't have so many drugs available. Only one drug available. This was the result with 4 out of 6. But with 2 drugs available, the results were better. And it did the naive patients with HIV about 200 copies per ml, and we have no active infection associated with ethnicity or only with that, or only with peak. So as you can see here, there's 3 strategies, including one that is only dual therapy, TAF, acamprevir peak and acamprevir, or the acamprevir plus ethnicity, and the comparative group, integrated ethnicity, and the numbers are about 80 to 90% efficacy, so it's a very promising drug. So also BNAbs, floating universal monoclonal antibodies and the HIV are studied as compounds that could help for people that are in desperate situation like those facing that example, which so this is a process progress that could help patients that are having difficulties. So it could be probably a kind of for a combination for solvents, which the anticoagulation basically has 2 and 3 drugs, potential candidates that we may in the future, and I can be still ongoing. Maybe cabotegravir or so as you see there, and it could be also a paradigm for disease prevention, in which it could be used as I said, in different situations, including HIV. You know that PrEP is strongly recommended by different regulatory agencies and regulatory bodies. The guideline for CDC include monthly injectable cabotegravir without the regular for adults and adolescents with 35 kilograms. The advantage which we get that's the situation. It's very important to monitor the space because this is a PrEP study.
apply the studies for the patients that really are in a situation of risk. So there is two studies that were mentioned yesterday by Dr. Lombardo in the sessions. Study 083 and 084. Study 083 was done in Western countries and Latin America by an institution which was study. MSM and the women with respiratory infection, namely patients with STIs in 6 months, several different sessions, etc. And the study of 084 was done in Southern Africa, sexually active young women at high risk of HIV infection. And as you can see, the MSM and study, the number of HIV infections was here is beginning with after 1 year of applying period, I mean, of the study was stopped, this followed what is happening at the period and everything patients,
Professor, we are with some problem with your audio. No, it's maybe if you change the phone, the mic.
Now it's better?
Oh, it's very, yes, now, very good now.
Oh,
it's better.
So, I don't know.
Yes.
I continue from here, okay?
Yes, okay. Thank you.
I was saying that in the HPD 083, you can see that 1 year after the unblinding period, 11 infections occurred in the cabotegravir arm and 31 infections occurred in the tenofovir FTC arm, which is a very good combination for PrEP, but it's really inferior to cabotegravir. And if you analyze the total efficacy during the study and 1 year after, you see a total of 25 versus 72 infections with 34 efficacy showing superiority. But to be taken in account, 7 breakthrough infections of cabotegravir, despite the injections were given on time, and the concentration was approached. So it's very compelling strategy, but it's far from being perfect. And a situation that we need to take into account is that when a patient is on PrEP, regardless of cabotegravir or tenofovir FTC, what you see is that there is a delay in the antibody antigen test compared to qualitative HIV RNA testing. So for cabotegravir, there be after even 2 months, and actually 3 months for incident infections, and for FTC is about 1 month. So that's why the recommendation is to follow those phases of cabotegravir with as a PrEP strategy to control them with antigen antibody testing. But if the antigen antibody testing is negative, you may wish to do a viral load in order to avoid any kind of incident infection and having the patient on monotherapy with cabotegravir. If you have, for any reason, the use of cabotegravir as PrEP, it's very important to know that the concentration will fall, and then you need to cover this zone of resistant risk with FTC TAF or FTC tenofovir within 8 weeks of the cabotegravir infection, and continue follow-up quarterly to assess PrEP needs and complete HIV testing. So at least 6 months to 1 year after for FTC, if you stop chemotherapy for PrEP. So the critical points on PrEP is that it should be discussed with all sexually active patients that are at risk of acquiring HIV infection. Chemotherapy injection was found to be superior to standard of care for FTC in men and women, and was FDA approved. There were some breakthrough infections despite on time dosing. The CDC recommends HIV to antigen antibody testing for all patients on PrEP. And I refer you to the CDC guidelines to see more details regarding the dosing in this population. So my final slide was just to say that we have new therapy, which is good news. 41 years after the first description of AIDS, what a long way really. What was a uniformly lethal disease has been transformed in a chronic asymptomatic status controlled with a single pill and maybe with an injection every 4 or every 8 weeks. The road now is open for flexibility and new paradigms, and Ribavirin is the first combination that is paving the way for further progress. We have several challenges we discussed. I will not repeat it, and be reminded that chronic hepatitis B, pregnant women, prevention of vertical transmission, communication with drug-drug interaction has to be considered. So far, we didn't see any potential for severe toxicity, but it might happen when the use of this combination is wider. So we need to be alerted about that, and eventually we need to discuss how to rescue a case of unforeseen allergy or toxicity that, again, after thousands of patients having received this combination, has not been reported. So discovering new focuses in less drug, new mechanisms of action, and long-acting drugs. And I thank you for your long-acting attention. Thank you very much.